Welcome to the Doctors Making a Difference podcast. I'd like to welcome Mahesh Karandikar and appreciate you being on the podcast today. Do you mind introducing yourself to our audience today?
Sure, certainly. Thanks for having me. My name is Mahesh Karandikar, and I am one of the assistant professors at the University of Washington in the Department of Neurosurgery, subspecializing in spine, so spine surgery, predominantly tumors, as well as degenerative conditions and some minor amounts of trauma.
That's pretty neat. So you kind of think back to, I mean, it's kind of an interesting career. Neurosurgeons are in residency notoriously for a long time, and you've been able to not only complete that, but you've been able to achieve a position within a distinguished university and help people with, sounds like some pretty interesting stuff with like, especially tumors. That's got to be very hard to uh, tease out of the tissue so that you leave the person neurologically intact and still extract those. That's a pretty interesting career path, I would say.
Yeah, I mean, it's like I suppose anyone's career. You have to really love it, and I think if you enjoy it, it does make it a lot easier because it is pretty consuming, as I think all specialties in medicine are.
I did too. That's what I wanted to kind of ask you about is how did you decide as a young man, you're kind of deciding where to go and what to do with your life. Did you envision you'd be a neurosurgeon someday? Was that the objective when you started, or how did that evolve?
That I would say it's primarily based on two things. I would say I went to medical school at the University of Texas, and it was a mentor there who was the boss of the department who just sort of captivated me. Not only because he was such a great neurosurgeon, but he was such a great person.
Hmm.
Sort of a inspiration, really. And so that's what drew me to the field because I just couldn't believe how humble he was and yet how good he was, which I heard from everybody else except him. And I would say the nature of the patient disease that we dealt with, I thought it was so incredible to come down to the ER and just see sometimes really sad stories, terrible car accidents that alter people's lives forever, or like you said, tumors or other things that affect the brain or spine that really changes one's life. So it captivated me. And I think it just made me think that, wow, there's an element of stuff that you can't control and it's nice to be aware of this. And I think it really reminds us of, your gratitude.
Yeah. Well, and I just kind of think a lot of the people that listen to this podcast are medical students or early stage doctors, and I think some people in that early stage, they look at the long career path and they say, okay, hey, I've finally gotten into medical school, or maybe someone's contemplating that, and they see this long time horizon and say, if I finish medical school and I complete a residency for 4 years, or in neurosurgery 7 years, or people go on to subspecialize, and so it can be really long. And so you made that decision, it sounds like, because you're super inspired by someone that not only had the skill set but was also just a humble, nice, gracious person. And those are usually the best kind of examples for sure. What would you say to someone who's kind of in that early stage who says, I'm not sure I could take this on? It's a long career path, and sometimes the joke is that neurosurgeons are in training so long you don't actually ever meet any neurosurgeons. You just see them; they're forever in residency and fellowship. So what would you tell someone who's in that decision path?
Yeah, I guess it would be very much the same as it is for any of the specialties, but I agree that it's perhaps a lot more years. But I think it's if you just enjoy the process. If you're looking at being a neurosurgeon on the other end as your ultimate goal, then you could be disappointed because the pathway may not be exactly what you planned for or expected. But I think if you feel you can enjoy the process, and that's just doing your research and looking up, what people are really doing, and not worrying about what people think neurosurgery really is, but just following some residents or neurosurgeons or students who are already interested. I think if you can say you love the process of getting there, then then you're going to love it. You're not going to have any regrets.
Well, I mean, and you've already kind of reflected on that, but it sounded like it wasn't when you first started. It wasn't that you had this perfect vision of just suddenly walking out being the neurosurgeon. you wanted to follow the example of this other gentleman who you'd worked with, and you could tell he made a tremendous difference to all these people who had entrusted him with their care. And I mean, that's a powerful story. And I think that I hope that exemplified to you throughout your training so that you could stick with the hard times, because you have to pay the price. You can't become an expert at something unless you do it a ton. And that's true for every specialty for sure.
Yes, I totally agree, and I feel like just that the gravity of the situation. I remember so many of my classmates who didn't want to do neurosurgery. Some of them said how it's so depressing because of the patient population and the pathology that we deal with sometimes, and that was exactly what I was intrigued by because it's happening, and I just thought, boy, there's no better way to stay humble. And when you walk down there at 2 a.m. and you see somebody the day after Christmas getting into a terrible car wreck. We know it happens. We read the papers. And so I thought that's what captivated me. But by the same token, it's, I guess it's sort of finding out what you really love and what really makes you tick.
Well, and I think my experience as both a doctor and as a patient, I've been a doctor for enough years to know what it's like to be a doctor, and I've shared on this podcast some of my health experiences. It's a pretty humbling thing to to go and ask for help, but when you go to someone and realize this person dedicated years and years of life to become good at this one thing, and in this moment at that time, it made all the difference. And like you described, the person at 2 a.m. who's been in a car wreck and the loved ones of that person, you come in and you say, I've got this skill set and I can help you right now, even though it's an inconvenient time. You're there to help them. That's a pretty powerful thing.
Yeah, that's a really good point. I feel like I also have been in that role where, maybe many of us have, where we were the patient. And it is amazing how different but necessary that perspective is. And I think on the other end, when we're actually the physician or the provider, I think it's really great to sometimes be in that other role because you sort of have a different sort of empathy, or maybe it modifies your empathy a bit and increases your patience, I'm sure. So yeah, I agree.
Yeah, I had a large abdominal surgery, and I remember the surgeon, the kind of talking to me about that and saying this is what it entails, and she herself had been through a surgery and was kind enough to share some of those experiences with me, and you realize this is more than just doing this because I want to have a job or I want to do this just to impress somebody. It really has to come down to the person who you're serving, and especially I think the longer you are in this game, the more that means to, I think most people I've talked to tell me the same thing. And I've found the longer I work in it, the more it becomes about that patient relationship. It's not about, oh, I got to get this next step and pass the boards and then take this step. And you kind of go through it sequentially when you're in training. But in practice, it has to be about patience. And you've kind of hinted around that. That's a pretty powerful thing, I would say.
Yeah, I agree. I think it's the intangible fulfillment that you see later when you've left the sort of the coursework behind and now it's just you and your practice and your colleagues and your patients. And I feel that's the most satisfying thing.
Yeah. Do you have any stories or anything you could share? I was just thinking of, you have all these fascinating surgeries that you get to do as part of your career. I was wondering if there's any patient story or specific thing that you'd be willing to share.
Sure. I think it's it's sometimes the most profound examples for me have been, which is something I learned later in my career, are some of the cases where I didn't do anything. I didn't operate for one reason or another. And I'll never forget where a gentleman came in with metastatic prostate cancer. And so he came into the emergency room paralyzed. So of course we saw the MRIs that they got in the emergency room and immediately ran down there and said, okay, well, um, we need surgery. And he just looked at me, and he had carefully thought about this clearly beforehand, because he knew he had prostate cancer, but he just didn't have the mets to the spine. And so he said, no, I don't want surgery. I don't want. And then I talked to him for quite a while. And basically, in a nutshell, he just said, I absolutely don't. I don't want the quality of life to be compromised at all. And I couldn't guarantee that even if we did this, that he would return to being able to walk again. So I'll never forget that. Like I said, I spoke to him for a while, and the first thing he said to me was that, it's interesting that you're even talking to me for this long, because no doctor wanted to talk to me. As soon as I said I didn't want any treatment, they couldn't understand it. They were actually a little upset. And I thought, that's interesting. I think that may be how we can initially think, when somebody doesn't take our recommendations. But then you think about this gentleman, and I put myself in his shoes, and I could definitely see it. He didn't want to be a burden to his family, and that was very big on his list, both financially and physically. And so that sort of etched in my mind, that case. And then he ended up going on hospice and passing away maybe a month or so after that. And his hospice nurse came and contacted me because he said, he wanted to send his sentiments along, and he said, thank you for being receptive while he was in such a sort of dire situation. And I just thought that really made a indelible impression on me.
That's quite an interesting story. As a surgeon, a lot of the stories I'm sure are cool surgeries and things you've been able to accomplish, but that one really touched you because you didn't necessarily get to operate, but someone that mostly just appreciated your time and your expertise to go through something really challenging. That's interesting. Yeah, I didn't expect you to share a story about not doing a surgery.
Yeah, I thought we're so focused on the technical aspect, and I do love that, and it's so about me, that when something like this hits you, you really are forced to pause and think about it in a different way, and then you realize what you're really doing. It's not just about getting in there and doing the surgery, even though for me it maybe is, but you have to think of the other end and why you're doing it. I guess the underlying theme of why you're doing it. So that one always stuck with me.
Well, yeah, and it is like we said a minute ago. I think it's the relationships with people. So, like, I'm a primary care doctor. A lot of my relationships are kind of longitudinal over a prolonged period of time. I wondered how you've navigated that as a surgeon. Most people are coming to you for consultation, and they may have a surgery with a little bit of post-operative follow-up, and then they may not see you again, or they may if they have recurrence of whatever disease. And I was curious if you have any comments on that, the longitudinal nature of those relationships, or do you have to form them, quickly and move on? What's that like as a neurosurgeon?
Yeah, that's a great point. I think that's really by personal choice. And it's interesting you bring that up because there are patients I do like to follow. And I even tell them, I give them the choice. And now with Zoom, it's a more convenient. So I could just do, I mean, for them, it's no problem for most people. They kind of want to, you could do a Zoom visit, even if they're not local, uh, annually, for instance, just to make sure that they're progressing well and everything is fine. Some, of course, don't want to, and then that's fine. As long as they're fine, there are no complaints. They just follow up PRN. But I like that. It's very satisfying and of course, just like any human interaction, you're not going to bond with everybody in the same way. But when you do, for those people, I always like to give them the option of long-term follow-up. And in fact, it's funny because I just had a patient come back who I haven't seen for a couple of years. And she said, wow, you have such a memory. We were just taught, because I just happened to remember her, like, just personal things. And I just thought, that to me is part of the job satisfaction for sure.
Well, and I just think back to, I think all of us, when you first start medical school, we're all going to save the world. We're going to have the best relationship with everybody. We're going to be the best doctor. And I think if some of that has to kind of come back through in your attending physician years, because it is about those relationships and the bonds that you form with people. And, and I think you get to where you're pretty good at the technical aspect of what you do, and you do it again and again and again. And while it's fascinating, it sounds to me like a lot of the things are related to those relationships that you form with people over time.
I agree. I think it gives it a different meaning, a less selfish meaning. The technical stuff is very, I guess, very inward. Like, I'm really thinking about myself, what I want to learn, where do I want to go, what do I want to offer people. And it's really focused on me getting better as a technical surgeon. And I think that's great. And I think it's important, but it is very different than this relationship that you build with people over the years.
Yeah, that's great commentary. I wanted to ask you a little bit more about your career path. You went to Texas for med school. It sounds like, or walk me through it a little bit. How did you end up in a university professorship, teaching in that? But I'm assuming you teach and and do surgeries. I'm just kind of curious how that pathway proceeded.
Yeah, so it's very interesting. I graduated from the University of Washington in 2011 and then went to Wyoming to practice in private.
Oh, you
Again,
did.
yeah, with a
Interesting.
professor who was from Dallas who went to practice there. So he was hiring somebody. So I went and joined him. And that was wonderful for the reasons you mentioned about practicing in the smaller towns. It was just absolutely everything I thought it would be. And then my old boss from Seattle here called me up and said, look, there's a position. They purchased a new hospital, incorporated it into the university. And so they needed a spine person. So I jumped at the opportunity because it felt like I was giving back to the people who gave me so much in terms of teaching. And so now it was just extra satisfying. I always wanted to go back to the academic setting for that reason of teaching, especially like you said, after you've done many, many cases, you feel like the next step is to perhaps pass it along. And it was extra special to come back to your own place because you know everybody. And so when that opportunity came, I wasn't going to be inflexible about timing. Otherwise, I was going to stay in Wyoming longer. But then when that presented itself, I figured that may not come up again. So I came back.
So was residency also in University of Washington?
Yeah, residency was here. So I know everybody. They
Yeah, of
trained
course.
me.
You'd know
Yeah.
everybody there then for
Yeah.
that period of time.
Yeah, even in other fields. So it's like the family physicians, anesthesiologists. So
Oh yeah, I mean, the world of medicine is surprisingly small. You can be in large areas or large referral networks, but you end up going to a lot of the same meetings and you rub shoulders with people and refer back and forth. And I've found that it's kind of a small group. There's only relative to the population of the United States, that there's just not that many doctors. And so that
yeah,
is neat that you went back and found those same relationships with peers and colleagues and things like that.
yeah, it's been that part's been really special. And like I said, it feels like I'm giving back to the program that gave me so much. So.
Yeah. So do you interact with medical students, or do you teach courses, or are you mostly with residents and fellows, or what does your life look like now?
Yeah, mainly with residents, but I am part of the admissions committee here, so I interact with students in that regard. So undergraduate students actually trying to get into medical school, and then most of my teaching is certainly with residents, both didactic as well as in operating.
Yeah. One thing I wanted to highlight a little bit, you went to the University of Washington, which is part of the WWAMI network. And the people that aren't really familiar with that, it sounds like, I don't know, people don't like WWAMI sounds like a video game or something. So would you mind telling people what that is? Because I think it's kind of a special thing in the Northwestern United States that involves a bunch of states and is a pretty cool program.
Yeah, it's a very, very unique sort of situation here where WWAMI consists of Washington, Wyoming, Alaska, Montana, and Idaho. These are the states that are covered in the WWAMI sort of category. And that is responsible through the University of Washington here in Seattle. And so, for instance, the only level one trauma center for all of those states is here at Harborview in Seattle. And the medical school, for instance, is another example of how WWAMI is used, where students from all of those states are considered in state for their admission processes. So that works out really well. So it's not like they're disadvantaged because they don't have their own medical school. So that works terrific. So we have slots that are Alaska students, slots that are for Idaho, Wyoming, and Montana, reserved in our class, just like we would for Washington State residents.
Well, and I believe it's been going on for decades.
That's a good point. Yeah, I don't know exactly what year it started, but it definitely, I want to say somewhere in the 60s or 70s. So it's been quite some time.
It's a good example of kind of something that actually works. Government
That's a good point.
affiliations and state schools. I mean, it requires hundreds of people to kind of all be on the same page, and I think that's a neat way to do it. And you've got to go through that, and now you got to go back and practice in kind of your home institution.
Yes. Yeah. And you're right. That is a very remarkable thing the way they've constructed it, and it's really amazing how well it works. You're right, because the other thing that's great is in your field, family practice. I mean, I can't imagine people getting this kind of experience, which is absolutely amazing. They can go to rural Alaska, they go to rural Montana, and some places where a family practicing experience is so unique. And I think it's just amazing to hear what the students and the medical students tell me in terms of these rotations.
Yeah, we've had students come through my small clinic, and it is interesting because you get to see a little bit of everything. If you're in a rural site, you have no idea what's showing up because in those settings, I work in the emergency room and the inpatient floor and take care of nursing home patients and deliver babies and on and on and on. And so you don't know what's going to show up in the emergency room or the clinic, and so it ends up being a really varied, interesting sort of career. And as a student, all the rotations, I was at the University of Utah, which has a similar arrangement with Idaho, but I love those rotations. He's going to work with people that had, I mean, you have no idea what they had no idea at the beginning of the day what they were going to see, and they needed to be able to think on their feet and manage super complicated stuff that would just show up right then and there. And it's a pretty cool program. I hope that program will continue on for a long, long time, because it has sure been it's just been a blessing to lots and lots of people in this part of the world.
Yeah, yeah, I think it serves a great purpose, and it also is great for training because we really see so much, not only in one specialty, but all of the specialties. I noticed that they just see such a breadth of patients, patient volumes, pathologies, and it really plays out when you actually compare some of the other, other aspects or medical centers, I would say, in other parts of the country, even places that are typically more crowded, like the Northeast, but they just have so many institutions that it's spread
That's
amongst.
true.
And it really, you can really see the difference. It's amazing. So,
Oh,
yeah, I feel very grateful. And same thing with the University of Utah. It's the same type of thing. And University of Oregon. I mean, it's just really amazing. I think this part of that of the country and the experience that it sort of gives because of that, this huge geographical mass that's covered by very few centers,
oh
um,
yeah. Well,
lends to
and
a
another
great
thing.
training.
I mean, this is not a political podcast, but I think it's interesting in a time where everybody seems to be divided and they're so strongly opinionated about everything you can think of, that this has persisted. That people have been able to maintain this five-state coalition across multiple decades, across different administrations, across political lines. I mean, it's been like an outward focused thing where, and the University of Utah and the state of Idaho have a similar arrangement. It's really kind of a selfless endeavor to say, what do we do to make sure we have well qualified physicians for these states with lower average population? And boy, you still need doctors no matter where you go.
Yeah, that's a really good point, actually. How effective it's been despite the divisions outside of medicine. That's really true because it's really going strong, and everybody seems pretty content and happy with it, and it's efficient. It really is efficient. I mean, and I see this firsthand with the admissions process, because we really heavily rely on the WAMI. In fact, we just did Alaska. This Friday will be Alaska student sort of review, and it just works. It really does work.
Yeah, I think it's pretty neat. You got to be involved in that. Now you're still involved in it, so that's another way, like you said, to come back to your home institution and give back. And then I know you highlighted a little bit on your information that you've gotten the ability to do some of these minimally invasive surgeries for some of the folks. And I know I refer to a network of neurosurgeons, near where I'm at, and it just depends. A lot of them have some of the minimally invasive skill set, and some don't. And I was curious how you acquired that, and what, how do you use that in your normal care? Like how does that fit into the rest of your training?
Yeah, that's a good point. I feel the field of spine surgery, probably all fields, but I can speak to spine surgery where it's evolving so quickly. And I've always felt that if you are not evolving, you're really going to be left behind, because it's evolving so quickly. And when you see what some of the new advancements allow patients in terms of recovery, getting to there with less pain, it's just amazing. You would sign up for this versus something very old. And once that happened, I just had to sort of commit myself to that. And I think I've always, and that's more the selfish part of, I think, practicing for me, is trying to make sure I'm on top of it technically, and whether it be learning new things or getting even more proficient at the things I know. I think that's very important. So I think I've just always dedicated myself. I used to tell our folks, where we had these representatives from companies come in, where I just said, just please bring me 5 new things, everything that's a year. Just give me 5 new things that have come out this year. I don't care what company it is, and I don't care what it is. And I anticipate that 4 out of 5 won't be that useful for one reason or another. But even if I could find one, then over years, that's quite a few techniques. And that's what they did. And here, we've continued that. So we've just asked for people to just keep bringing new things, and then we can decide, if based on patients, if it's worthwhile or not. And some are, I would say more are not, but if you don't look, you'll never find them. So yeah, I love that. I really, really love that. And I think endoscopic spine surgery is probably the new frontier, but just not quite there yet in America, but it will be, I think.
Oh, that's pretty. Yeah, I don't think it's selfish at all. To you use the word self, but I mean it's self. It's exciting to be able to learn a new skill and all that stuff. But truly, the person who you're serving is truly benefited by that. Because if you can send somebody out with 1 day of hospitalization instead of 3 days, or the recovery on that is so much less, and I think that makes a big difference for people in recovery. And then people, they'll refer their friends because they learn to trust you and say, hey, this is something complicated that I wouldn't want to go through, but now I have to because my body broke. Everybody's body breaks. And so the more you can do that with the less invasive things, the less likely you are to cause damage to the body that can't be recovered from.
Yes, that's definitely really borne out in, like you said, in recovery, patient satisfaction, long term, and consequences from the surgery. Some of the older techniques that we use, and sometimes still use, do have consequences that require further surgery down the road. If we could even lessen that, it would be really nice.
Yeah. Well, and that's probably part of the benefit of, like you said, working at university. You're in a place where they're always learning new stuff and new techniques, and you have a group of people you can bounce ideas off of. How many people would you say work in your department? Because that's a benefit of working in that sort of a group.
That is very true, Peter. We have about 30, so
Oh,
it's
wow.
quite a big department. Yeah, quite a big department. 30 neurosurgeons. There are others like researchers as well, but about 30 practicing neurosurgeons across uh, 5 hospitals. So it does serve that purpose very well, especially after coming from Wyoming. You just see where it's just easy to interact with your colleagues. In fact, sometimes we have to, because we are doing joint meetings where we present cases. And I think the one thing that's been exhilarating for me, that's been a bit of a surprise, was the as I get older, it's probably more impactful. This to see the youth and their enthusiasm and their innocence and learning. And like you said, when we first went to medical school, it was, we wanted to do such a good job and help people. And that sort of innocence and enthusiasm is inspiring. It prevents me from getting to be too bitter or anything of that sort.
Right. You don't want that. Well,
Yeah.
so, you worked in Wyoming in a place with a lot fewer colleagues, I'm sure, than where
Yes.
you're at right now. And I have another friend who works at a university setting, and it's what he told me. He said the very best, like, he loves what he does and he loves teaching and he enjoys working with a group of peers. But he said the benefit to his lifestyle also helped a lot, because he said instead of sharing call with 2 other people, he's now sharing call with 30 other people. And so when you want to trade, or when it's somebody else's turn, you're suddenly pulling from a lot bigger withdrawal pool. Whereas if you're in Wyoming, there might just be a couple of you and you're kind of on call all the time, or a lot more frequently. So I was just interested to hear you compare and contrast those 2 jobs, because that's interesting. You've worked in both settings.
Yeah, absolutely. That's probably the number one thing. I mean, I would never take God forbid, I would never go away for the weekend if I had a big case on Thursday or Friday.
No way.
Where now I feel that that's doable because we have so many people between residents and other colleagues that are here that you never feel that the patient is will be unattended. And just tell the patient that, oh, I was and I'll be out of town this week, but so and so will be here. So that is a huge, huge change, that's for sure. And so the lifestyle does benefit from that. A little more sleep, and yeah, I think prevention of even burnout. At least I feel that.
Well, yeah, and I've found for my own life, and other people I've talked to, that I think burnout comes when you don't feel a lack of control, or when you feel a lack of control, when you feel like you have no end in sight because you're asked to do more than you can possibly do, and you can't balance the other important parts of your life, and you just kind of feel empty because everything is overwhelming. And so that is one nice way you've been able to find a way to do it, is you're engaged in what you do, you love your patients, but you've also been able to find a way to share the burden a little bit so you don't have to be gone from your other endeavors in life quite as much. And so what was that like in Wyoming? I was curious to kind of compare those two things.
Yeah, Wyoming in some ways was really like an extension of residency. I felt it was just always on. And because of that, like you said, it's less to share. And if there was a big case, you just didn't want to leave them, in case something went wrong or they had some questions and you weren't there. It's just reassuring, I think, to have your provider there, accessible if there are any questions that come up. So I think Wyoming is very intense in that regard. But the flip side of that is you just make these great relationships. Just you see them, they really appreciate it. Patients will appreciate it, especially on weird off hours coming in or seeing them when they have a question. So I think the flip side was definitely that there was a real strong bond with folks that develops from that kind of situation too. So like you said, I think it's pluses and minuses. I really didn't feel I was very equipped or intending to teach at that point. I really felt like I wanted to do everything, not turn it over to somebody. So that was also nice to graduate and then go straight into my own thing. But it was like drinking from the fire hose.
Right. Well, that's what I still think that sometimes that because I work in rural medicine, and I still reflect sometimes that it is harder than residency sometimes because you're always on. But the benefit of that, especially in the early years, is, boy, think about the numbers of the cases of the things that you just see it in a rural environment. You see it again and again and again. You can always call somebody, and you can send somebody to another facility if they need it. But a lot of times the decision making and the procedural capability, I mean, it has to fall on you because there might be a snowstorm and you can't send them anywhere. They're right there in your hands, and you got to take care of them.
That's a great point. Yeah. I really feel like all of us are sort of in this as a lifestyle, as much as we think otherwise sometimes, or want to think otherwise maybe, but it's a lifestyle. I mean, with a business, you could close it. With, you could go away on vacation. Here, I just feel like we can never really close it. We can never go away in any specialty, maybe at least specialties that deal with patients.
Yeah.
It's really it is interesting. So when students ask me that, or undergraduates ask me, I said, just figure out if you're going to love it. Go do whatever you got to do. Follow physicians. Figure out if you're going to love it, and you're not going to dislike maybe some of the arduous things too much. The love is going to carry over some of the arduous things. I feel point. Like I just feel like that's important, so that you don't become disappointed, and bitter.
Right. Well, and to that end, that's a good question I wanted to follow up on. Is, we talked about burnout, and you and I'm sure have both observed plenty of people who are bitter. They've gone through burnout and they're still in it, and they're not happy. They're not pleasant to be around, and they don't, you can tell that they're going through it, and they might find some aspects of the job enjoyable, but that bitterness kind of shines through. And so or I don't know, the word is not shine, but they really it comes out through your interactions. So one of the questions outside of working in a university system where you have a lot of partners to share the work with, what other things have you found in your life to manage burnout? Because it's a real thing. I think almost every physician will at some point experience episodes of burnout where they feel like they can't control their life. And I'm just curious what you've found and what are some of the tips you would pass on to those who are a little bit earlier in their training.
Yeah, I feel I've become more comfortable as time has gone on with saying no, to 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 a variety of different requests, whether it be joining a committee or seeing extra patients or extending the clinic. I feel I've been able to say no more now without feeling as guilty. I think that's helped a lot. And then I'm sure everybody has their own sort of way of escape, um, from their job, whatever that is. And so for me, it's just being outside. So I'll go outside a lot, so even in Wyoming too. And boy, the winters can get really cold there. But it's just to me, I think it was just um, one explorer who said that, and I just can't remember who now, where he said that, when I'm out in nature is when I really am closest to God. And I
Mm-hmm.
just feel that that's pretty cathartic to me. But I'm sure everybody has their own things. Um, but that's what I do to get and limit it before I feel like it never ends, right? I think if you say yes to everything, you could literally never leave. And so that I think was the biggest thing for me, is to get over the guilt of saying no.
No,
People end up understanding.
I
Yeah.
think that's a good point. Like you said, if you say yes to everything, you could live there. They would ask for you to do something all the time, and so it is helpful to have the ability to say no and know when you can. And we've talked a little bit about on this program a little bit. You also don't want to make yourself like pigeonholed into some financial thing where you have to say yes because you're so overwhelmed. And I've come across people who are in that boat too. They say I bought the big house and the boat and all the things when I was right out of training, and now I've not paid off any of my debts, and so I have to say yes because I will be financially distressed if I don't. And so that's an important piece of this as well, is to play your cards correctly so that you don't. So you can say no because it's appropriate for your life and your family, and maybe right in that moment you're going to do the right thing to take care of the patient, but help set up a system that allows you to say no so you can balance it with your family. And curious if you had any comments or tips in that regard.
Yeah, that is a very interesting topic to me, especially as the way medicine evolves, and is evolving, especially when you compare it back 30, 40, 50 years ago. And so I feel some of the best advice I ever got was again in Dallas, where they're the guys, who I still keep in touch with. They're the guys who really turned me onto this field, not because of what they do, but the way they do it and the way they carry themselves. And so one of the guys told me, he said, after you graduate residency, he said, just live like you've been living for like 3 or 4 more years. And he said, and invest well. And that way you don't have to go into incur more debt and have problems later on. And I thought that was brilliant advice. And that's what I did. I remember he kept the same apartment he had as a resident as soon as he became an attending down in Dallas. And so I thought that was very helpful. And I agree with you 100%. Um, so I do live a pretty simple life. And in fact, that was my hero down there, Dr. Sampson. I mean, I'll never forget, he pulled up in a pickup truck. And I was like, oh,
Mm-hmm.
this is great. The boss of the neurosurgery department at the University of Texas in Dallas, who's world renowned, pulls up in a pickup truck. And I said, I love this guy already, and so um, it's to each his own, of course, but I think that's one way to get on top of um, decreasing reimbursement, decreasing salaries, and increasing tuition, the other end. So I really feel that's very important. And that's no different than any other field and any other financial guru who just simply says, live below your means, and I think if we start out that way, then we'll never have a problem.
I think it's awesome somebody gave you that advice when you were at the earliest stages of it, because you're right. If somebody falls into those kind of financial temptations and traps, or like, oh, you're special because you're a doctor, it's not true. I mean, the math has to work for everybody, and I mean, I've observed people get in a lot of trouble with that kind of stuff. That's actually, they gave you that advice, and you were wise enough to heed it, and actually had some examples of people that were doing it, and I think that's pretty cool that the chief of surgery would drive a pickup
Yeah,
truck.
he's amazing, that guy. Yeah,
So is he still in practice?
he's retired. He's retired.
Yeah. Well, that's cool. Did he keep the pickup truck through his whole practice?
Yeah, he has like a ranch. He's just a regular guy. He's amazing.
Oh, yeah. No, I think maybe not in Seattle, but in Idaho, a pickup truck is vital.
That's
Yeah.
true. In
I don't think
Wyoming
we could
too.
survive without one, at least because we have a small farm and ranch, and I have to plow the road. So like there, I have to have a pickup truck for all the time. But it sure is a practical piece of equipment, that's for
Yeah,
sure.
yeah, that's awesome. Yeah, 4x4.
Yeah, it has to
Yeah,
be. We
yeah.
live in snow country. There's a foot of snow on my lawn right now while we're recording
Wow.
this.
Yeah,
Yeah,
we did get a lot of snow in Wyoming too. Yeah.
yeah, it just kind of depends. But well, that's great advice. And so we've kind of covered, how to overcome some of the burnout and maybe prevent yourself, do a little bit of burnout prevention by investing wisely and living like a resident when you are in your early years. And
And it's the easiest time to do it,
oh
right?
yeah,
It's because you haven't really tasted much else. And so it's so easy. It doesn't even feel like a sacrifice.
that's
Um,
right. Yeah, if you move your family into a beautiful home in an expensive neighborhood and like, hey guys, we're moving back to an apartment in the rough side of town, they're gonna they're not gonna
yeah.
be real happy with that.
Yeah, that would be a huge adjustment.
No, that's really good. Do you have any other patient stories or things that you've thought of as we've gone along here? Because I still think those are the things that are motivate me and motivate others.
The patient stories, I would say, in my specialty, and that probably would interest some family doctors as well, because we see back pain so much. So when it comes to degenerative back problems or neck problems, spinal problems, say, that have nothing to do with tumor or trauma, I think this is a very interesting topic because it gets into such a gray area, very controversial, and everybody's all over the place because it's a gray area. So you have opinions from one extreme to the other. And I think one thing that's hard to learn in, at least for me, was hard to learn in residency was to decipher and to develop judgment on who should have surgery or who shouldn't have surgery and who would benefit from it and who wouldn't with the same MRI. That's the thing. It's with the same imaging studies. There's no big difference in the imaging studies, but here you have person A, here you have person B. One could benefit tremendously from the surgery, but the other one would not and would regret it. And so I think that has really come over time. And I'm still learning, of course, but um, I think that art form is really there, and that the radiology report and the radiology findings are only one piece of information and definitely cannot, in and of itself, dictate surgery in these types of spinal conditions, right? So not trauma, not tumor. And I felt that that's been very helpful towards me having a much sort of more fulfilling practice because the patients are happier, and so a lot of times I'm finding myself talking them out of it, or at least putting them in the right perspective, because sometimes they also come in with a very high expectation of surgery, and I think it's really our job is to inform them and educate them that it's definitely not the be all end all when it comes to low back or neck pain. And I think that's been very, very helpful
No,
for them.
no,
For them.
and you're right. I think you described it well. It's an art form. I mean, you have to learn not only what does the imaging show me, but what is the person's overall probability of recovery. And it brings to mind a story of a guy that I cared for a couple of years ago, and he had low back pain. He had one of his I forgot which leg, but he had significant radiculopathy type symptoms, and it had been persistent, and it seemed pretty acute for several weeks, and just all this stuff, and it's a story that we can all come across. But he saw the spine surgeon, And thankfully, this gentleman had the wisdom to tap the brakes because the MRI showed, a lot of pathology, a lot of degenerative disease on his back, and he had radiculopathy symptoms. But he had the wisdom to tap the brakes and slow down and say, I think maybe something else is going on. And he just had a huge psoas abscess, but the guy didn't have a fever or anything like that. And so it was interesting, from a clinical standpoint, it was an interesting case because the patient was in the neurosurgeon's office expecting spine surgery to relieve his nerve compression, and he had an MRI which suggested nerve compression on the same side of his body where he was having symptoms, and someone that maybe wasn't quite as attentive would have been quick to jump into surgery. But I was appreciative that surgeon said, hold on a minute, because he did a bunch of exam findings and reviewed it and just said, I just don't think it makes sense. And maybe that's, I've just always thought that was a good thing that he did, because it would have been, had I sent him to somebody that was a little bit earlier in their career, or maybe someone that hadn't taken the time to really stop and listen, he would have been slated for surgery, and it wouldn't have corrected his problem, and may have certainly, caused him problems because he had an active infection that hadn't been picked up on imaging, and he didn't have a fever. So it was a very crazy
Yeah,
case.
that is terrific, actually. That kind of sort of clinical acumen is very useful, right? And obviously benefits the patient a lot. And this reminds me, this is, I think, one of the things etched in my brain too. And this was in Wyoming, where I was just starting. So I felt that I was technically fine, right? I took a lot of pride in my technical skill. And that's why I thought I said earlier, where I feel like some of the cases I didn't operate on were the most memorable. So a friend came to me. So a friend came to me with this horrible leg pain, low back pain, and a horrible disc on MRI, and absolutely did not want surgery. And I said to myself, while I was looking at the MRI with him, I said, they're thinking to myself that there's no way we're going to avoid surgery, but they really didn't want it. So I said, okay, well, that's fine. They didn't have cauda equina, so I think it was safe to not push it. And so I just thought it was going to be a matter of time when they came back and said they absolutely wanted it. But we watched, of course, and we were friends. So when the symptoms finally resolved after some chiropractic care and physical therapy, it was about 2 months, but the first 2 weeks were the worst. I remember he couldn't sleep for those first 2 weeks. But anyway, when the symptoms resolved, I said, let's just, for didactic purposes, I'm just curious because I can't believe you're asymptomatic now. We got an MRI, and that disc, which I never thought would have ever reduced. And I thought that was the
Really?
best lesson for me. And so I tell patients that to this day. I said, you're 20 something years old, if like this recent patient that came in, 20 something year old, fit, and you have this horrible disc. I said, well, I've seen a disc this bad go back in without surgery. And that just uplifted her, and I think so there's so many different ways to learn outside of the classroom or the rigidity of residency. And I think that's good. And it's ironic that it's when it's not, when we're not operating.
Hmm.
So so I feel that's really pertinent to degenerative spine, just like you said. I think it's really important to sort of put the brakes on sometimes for that. And I've learned that, sometimes not such a smooth way, but hopefully I'll keep getting better at
Oh
that.
yeah, no, that's why we call it practice, right?
Yeah.
No, all of us are a work in progress, and I found for my patients, I I strongly prefer to send patients to surgeons who know how to say no. And so if I start sending patients to, if we get a new doctor in the region, and every single patient that I spent, for a spine surgery, every single patient gets slated for spine surgery, I stop sending them because I know I'm not that good to perfectly discern this one needs surgery and this one doesn't. I'm not going to send them unless I think they may be a candidate for it. But I found that the very best surgeons are the ones who send the patient back and say, hey, we need to try X, Y, and Z before you commit to something that's, a permanent change to your body, unless it's trauma or tumor or something like that. But for the ones with degenerative changes and to that end, there's a lot of information about artificial intelligence and the ability to access information. And my patients usually come in having a whole bunch of knowledge about something because they've been able to, navigate the internet with all the AI features, and they really have a pretty good they have a pretty good handle on the information, on the what, and maybe even the why. But that discerning feature to say, but should I and should I not, and which of these three steps is the right one, and I think that's what comes with the residency experience, and then just being in practice, like you've been for a lot of years.
Yeah,
So
that is great actually. And in fact, sometimes I'll direct them to that so that they can research it. Because I feel that sort of, I just tell them, I said, the more informed you are, the more interesting their clinic visit is, because then I'm not talking as if I'm speaking with someone who absolutely knows nothing versus somebody who's already done the research. So they're asking me, pretty specific questions. It's just more interesting. And of course, it helps them. And so I agree with you. I think that's really changed stuff because when I hear some of the older generation talk about how they practiced, I feel that's been a big change with how easily they can get information. It's unbelievable. With, like you said, especially these open AI systems.
yeah, and it'll be as we go forward. I know I hear people bemoaning the idea that expert knowledge sort of fields will be replaced by AI, but I don't think physicians will. Maybe there's some specialties that'll be affected, but most of the stuff, that art of medicine of who should get what and looking at it, that's going to be hard to replicate with a machine learning, computer based learning, because there's a lot of factors that go into it, but the wisdom and understanding of this is a person that should do this or we should wait. And it sounds like you've gained a lot of insights on that through your career.
It's just almost through trial and error, I feel, and just looking at my logs over time because I don't know, I try to actually see how I could um, convey that to the residents. But maybe when I was thinking about myself being a resident, maybe I wasn't even receptive. So even if they taught us that or tried to teach us that, maybe I wouldn't have taken
You
it
don't even
in.
know what good advice you're getting at the
Yeah,
time.
yeah,
Yeah.
because maybe I was just so obsessed with just trying to learn the technical part. And so I don't know, but it is very interesting. I feel I really learned the art of medicine after residence.
Yeah, me too. I mean, I feel like I got good training, but sometimes you don't know what you don't know, and you can't really be in a place to receive the advice or the learning until you're at that stage. And that's one of the blessings of having a prolonged career and then working with a group of people like you do in a large 30-person group. You'll have a lot of collective wisdom in that group. Well, Mahesh, do you have any other advice? I mean, I think this has been a fascinating interview, and I think it's been interesting to kind of cover the breadth of working in a more rural or just a smaller environment back to the university, and we've covered a whole bunch of stuff. But I was curious if you had any other thoughts or insights for our audience.
Um, Not really. I guess if there's anybody who's in considering entering medicine, like you said early on, or which fields to enter, I just feel like it's so trite but so appropriate that trying to find something you love, and like that person said, who if you haven't found it, keep looking, because when it hits, then it just you're not working anymore,
Yeah,
and that's probably good for any field in medicine because it is pretty consuming and it is a lifestyle.
yeah, you have to find something you like, and if you can play your cards right and not get yourself in financial trouble, it can be such a rewarding, awesome career. One of the goals of this podcast is to try to give doctors tools to stay in medicine and keep making a difference, not depart because of being burned out. And it makes such a difference for the person who's entrusting their care to you and sometimes entrusting their very life to you. And so I appreciate what you're doing, Mahesh. This has been an interesting insight into to a person that's been doing it for a long time, and you have a good insight and understanding of not only the practice of medicine but also the training of learners. And I think I think it's a really interesting perspective, and I really appreciate you taking the time to share it.
Oh, thank you, Peter. I enjoyed it. And actually, that's one thing that's very interesting. Just quickly, I'll mention is because you brought that up as well as I feel like the financial independence, if we made that a goal, then we can say no. Because I'm saying no more now because I don't have that financial pressure. And I feel like that we can all do that if we start out of the gates in maybe a different way. If that's a priority, that is very useful because you could say no. I want 2 days off, or I want 3 days off, or whatever the case may be, um, because you could do it. It's not going to change your lifestyle at all. So I think that's really
I think
important.
you're right. I wish that I could tell every single person in that training, in medical training, that same thing, like, hey, don't fall into this trap, because I promise when you're in your 40s, you're going to want to be able to have the ability to say no, and you don't want to be financially constrained. And it truly doesn't matter what specialty you go in. If you play your cards right, you'll be just fine. But if you do a big investment and start living, way beyond your means when you're right out of school, it will do nothing but hurt you. So no, it's good wisdom. And so you can teach all your learners, all your residents, and hopefully they'll get that message, and we'll try to keep getting that word out. But
Thanks a lot, Peter. I really
yeah, it
enjoyed
was
it.
wonderful to talk to you, and I appreciate it. We'll talk
Likewise.
to you later. Thank you very much.
Thank you.
Thanks for tuning into the Doctors Making a Difference podcast, and thank you for what you do to help your patients and your community. Your work truly helps so many people. We produce this content to help you have the tools you need to stay in medicine and to highlight the amazing work being done by physicians around the world. Please note that while I am a physician, and many of the guests on this program are also physicians or other professionals, the discussions on this podcast do not represent my employer or any professional organizations to which I belong. This podcast is for your information and entertainment only, and should not be taken as professional advice. You should seek appropriate professional advice pertaining to your own situation. Please check out more of our content on our website, doctorsmakingadifference.com. Also, please follow, like, or subscribe on your podcast player or YouTube channel, and give us a 5-star rating. It really helps to spread the message. Finally, if you'd like to be a guest on the podcast, or if you'd like to nominate someone else to be a guest, please visit the website or email admin@doctorsmakingadifference.com. See you next time.